Hi, I'm Mark Raven. Welcome to part 2 of our video discussion series on lean design for healthcare. We're joined again by Miguel Burbano. He's an architect and a senior vice president with the Neenan Company. And we're also joined by Dr. Randall Huss from the St. John's Rolla Clinic. So today in this segment, they're going to be talking about their open workspace design, how that was driven by lean principles, and how that impacts the way doctors, nurses, and staff members work together in the clinic. To view all of the segments of this series, you can go to leanblog.org/leandesign. Miguel, tell us about this big open workspace and some of the design decisions that went into that.
One of the early, there's another current in healthcare today, national trend, if you will, about patient-centered design. The focus has shifted from the provider to the customer, client, or patient. And it is important that we also understand that in the Rolla project, we had to deliver for that population, that the intent was not only to improve the processes and create a beautiful building, but also was to create a different delivery process for the customer, for the patients. When we do surveys, time after time, we find out that one thing, all patients, regardless of what modality, resent waiting, resent wait. They feel it's a lack of respect. They feel it's unnecessary. They feel it is a symbol, if you will, of a not very efficient organization. So from the onset, we decided that we were going to eliminate waiting rooms, and we were going to create more of a hotel experience in the lobbies and the open spaces. So it also turns out that we can use those solutions to enhance privacy, to enhance the transforming experience of the patient when they go to a healthcare facility. So the open space serves as, it's a transitional space from the outside, before you go to your appointment, enjoying more of a hospitality environment before you go into the true medical settings, while maintaining great levels of privacy, having access to coffee and televisions, and without disrupting the traditional and quite correct privacy of the medical encounter.
Miguel, how does that workspace help the doctors and nurses, for example, collaborate and work together differently?
One of the things that we were very specific in the project was to eliminate my rooms, my office, my patients, my nurse, and instead create teams. So in order to do that, nurses' stations have to be congregated as opposed to distributed. That allows some collaboration to occur. So that immediate collaboration or in proximity also eliminates the need for supervision. The staff can supervise themselves. There's no need to have a supervisor amongst themselves to make sure everybody's doing their job. It becomes peer, real-time, open management. The proximity with the providers create an affinity, a partnership with the provider and the caregiver. As a result, the care team or nursing corps in Rolla are not only technologically different, they bring about all kinds of new technology to that work setting, but they also enable different work behaviors, accountability, responsibility, collaboration, participation, etc. And so the driver of that environment was that. Challenges, how to keep the sound levels down, how to keep the technology from infringing each other's space, etc. And we were quite pleased with the outcome.
Dr. Huss, can you talk a little bit about some of the design process and factors that led to looking at the work differently, looking at a care team model and how that should impact the layout?
We were much more steeped in the lean design principles. Plus, we realized we could now go in completely paperless because we were going to be about 11 months from go live on Epic until we actually implemented, or we were actually moving into the building. So that gave us the ability to really go in without paper storage. Previously, we were going to have to figure out places to store paper for a while, since it was going to be almost simultaneous when we went live and went live on Epic and went into the building. And that gave me nightmares, I must tell you. The thought of both going into a new facility and implementing an electronic record new all in a very short space, I didn't know how we were going to pull that off. Well, so it really was serendipity that we were asked to go back and relook, and it set us back a year or 14 months or so. So at the end, we were able to be in nearly a year before or after we gone live on the electronic record. So as a result of that, our design thinking changed, and we seriously looked at how to get non-value added work out of the business units. How do we keep just the people that are caring for the patient there, and move the other stuff off to what could ultimately be much lower cost square footage? We went out to the University of Utah and saw what they've done with some of their community clinics out there. I run into Robin Lloyd, their executive director, at an AMGA CEO President's Council meeting, and telling me what they were doing out there, how they developed this lean-inspired workflow redesign called the care team model. I think others, such as Virginia Mason, have also done some work along this line that's been very pioneering as well. Well, when I went out there, and then Miguel the first time, I saw a model that really works, this care team model, breaking down the old one-to-one nurse-to-doctor relationship and instead working in teams. Because if you really think about the old one-to-one nurse-to-doctor relationship, that's based on the paper record. The paper record can only be in one place at one time, and therefore it has to stack up in front of the nurse, and then it has to stack up in front of the doctor, etc. So when we take that out and we go with the electronic record that's everywhere there's a computer, our thinking became, what else can change? How do our workflows change, and how can design support this new functionality? We're going in with a very robust electronic record. It has a lot of capabilities. We know you can take an electronic record and just stick it in paper workflows. We see it all the time. I've got clinics in other parts of our organization where that's all they've done. And yes, it works, and you maintain your old paper workflows because that's the way we always did things. But it isn't. You never leverage the advantage of that electronic record. So that's what I really intended to do as we went into the second iteration of the building. Let's leverage what we can get out of this great electronic record, change our workflows. Lean is the tool to do it. Lean is the tool to question why we would do things this way. Is this adding value? Would our customer be willing to pay us if they saw us doing this part of the job? Or can we get this job either behind the scenes, out of the way, retool it, and make it more efficient? And then how does form follow function? How does the design then optimize and allow you to implement this new lean workflow? So that's really where we went with the second iteration, and that's where we got to the current design we've got now.
And Dr. Huss, talk us through some of the highlights about how your clinic is different.
Okay, well, the first thing you'd notice when you walk in is there's not the big wide walking hall with the doors off the side with the doctor's names on it in the typical tenant-style medical building. You're welcomed into a very comfortable galleria with comfortable seating going down. So it's one of the themes throughout this building is that there is multiple uses for space. We try to get the most efficient use of space as possible. So we've got comfortable seating out in the galleria. The reception areas, we don't call them waiting rooms anymore because, as Miguel would say, why would you build weight into your processes and your facility? So these reception areas now are glass walled. There's like an 8-foot wide opening that just opens directly off of the galleria, and inside there is a desk with a no longer really the receptionist, it's a greeter. We redesigned that entire receptionist position. I'll get to that in a minute. So what you see, you come in, you have a very welcoming, warm, friendly environment in the galleria, wide open, inviting entrance into the reception areas, which are very small. They're much smaller than the traditional old waiting rooms. For instance, we're using the modular pod type design. Each module in its initial configuration might have only accommodated 5 providers, 4 of whom would be in at any given time. But with lean design and standard rooms, etc., eliminating of the individual physician offices, which is another innovation we did in favor of the shared physician lounge, we've got 6 providers in, 5 of whom could be in at any given time. So that allows for that 6 provider office, there's 8 seats in the reception area. 2 of them are the double seats, so you could potentially, if everybody's not too large, you could potentially get 10 people there. And of course, in a worst case scenario, you can spill out into the gallery, and I'm not going to tell you that doesn't occasionally happen in a couple of our business units that haven't really gotten the lean workflow redesign done as well as some of the others. But normally, rarely do you see anything more than a couple of people in these reception areas. And that's what we saw out at Utah too. Since then, or in the course of looking at other facilities, I've noticed how big waiting rooms typically are. What a waste of space. You've got these huge cavernous spaces built for maybe that one time when everybody's behind and a disaster happens and you've got 20 people out there. But the gallery allows comfortable seating for people that come with patients, so they don't have to sit around in a waiting room, even if they have accompanied the patient and don't need to go in. So that's some of the different things you'd see immediately. The process is different. You don't go up to a sliding glass window and get asked information and things like that, because that's already been taken care of. We've used a call center, or we now call it a communications care team. We've taken calls out of the offices. Calls don't come into the business offices. So that function of the former function of the receptionist is part of the receptionist redesign. Those calls come into the communications center. The person when the first point of access to the office is typically the phone call in, and that's how we're taught in Lean. You look at the patient's experience from the moment they contact your organization until the moment they leave. So the moment they contact our organizations by phone, they use the same number they've always used to call our offices. But now the phone's actually answered by a person, and they don't get shoved off to a voicemail box. So there's an initial triage recording. You have a choice of 1, to speak to a scheduler for if you need to make an appointment. 2, if you need to talk to a nurse or it's a refill, then you get a nurse. Or 3, business office. After that, you're at a person, and they get all the information right the first time. We've had central scheduling for years, even before the electronic record. Central registration, I meant to say. And at the end of the scheduling appointment, if there's registration information needed to be updated, you're connected immediately to central registration, where the correct information is obtained the first time. And that helped us a lot years ago when we first implemented that with rejected claims, etc. So we've just kept that in place. So if it's a nurse, if you're needing a refill or you've just got a medical question, the nurses have protocols. They can take care of refills under protocols. If it's a call that just needs to go to the business unit, which is the vast minority, then it gets pushed down to the care team. The result of this is when we're in our offices, our nurses and our providers are taking care of patients. They're not answering phone calls. You rarely hear a phone ring. It's a quiet environment. I remember my old office. It used to drive me to distraction, hearing the overhead pages, phone call or call for Dr. H on line 3, appointment for Dr. F on line 4, billing line 5, these kind of things, and that overhead chatter was just really annoying. That's all gone. You have quiet, efficient offices now. When you walk when you get into the inside of the office, the immediate thing that someone would notice that's different is the care team area. So right behind that reception area, so as soon as a patient is taken out into the hall to be roomed, they'll walk past what we call the care team module, or the care team core. And this is probably the real innovation that's the most different from most current offices. We've taken the old nurses station, blown it up, and put the nurses' workstations around 2 triangular rectangular carousels, the points pointing towards each other with a walkthrough in the middle. So each three of the three sides can hold two nursing personnel. So you can there's two of them, so you can have 12 nursing. That can be LPNs or MAs, or in a few occasions maybe an RN would be in there, or some other caregiver. And then on the outside of those, we've got the providers' workstations. So all I've got to do is turn around and talk to my care team right behind me. And if I get a message through my electronic records in basket, I don't have to message it back. I can just say, hey, what did Mrs. Brown mean when she said she didn't like that new medicine I gave her? I gave her 2 new medicines. And oh, she meant the blood pressure medicine. So you can still talk, and it facilitates communication. And it's been a wonderful innovation, and it's a very efficient use of space with everybody right there. But with this team-based care, we've upstaffed to about 2 MAs or LPNs per provider in the team. So that allows for more nursing time to be in with the patient, offloading physician work. So that's part of the principles we worked into with this too. And that's another difference that the patients would see when they come in the room. The nurse is spending more time with them, taking more time to get background information, to reconcile the medications, they're not just putting down chief complaint, they're getting part of the history, they're doing the family history, doing the social history, and checking all these things, so that when I come in, all I have to do is just very briefly look at them and question something I don't think might be right or whatever, and then go right through it. And it's offloading physician work. If a physician doesn't have to do it, then make it so that someone else can do that work. So that's a difference that the patient would see. And then probably the other thing they'd notice at the end of the visit, they no longer go up to a checkout window to get their next appointment and finish up. We question, why would we need to line patients up at a checkout window? Besides, this design didn't really accommodate a checkout window. We just trained our care team nurses up on the scheduling module of their electronic record, and they make the next appointment right there in the room with the patient. So when we put the printers in the room, printers are in every room, so we can print off the after visit summary that's got their next appointment on it, all their to-do list, their medication changed, etc. It's all right there, and you hand it right to the patient, and they're escorted out, never having to go back. They don't even go back in through the reception area. They go out directly into the Galleria. So that's what the main difference is. I think a patient coming in, going through the flow, and seeing what they're seeing, that's the kind of changes they'd see.